Okay, Labor at Risk, Chapter 18. Dysfunctional labor or dystocia. This is an abnormally slow progression of labor. And dysfunction happens somewhere in those 4 P's. And remember, the 4 P's are passageway, passenger, powers, or psyche. So any kind of disorder in these 4 P's can cause your labor to slow down and to not progress. It's frequently a combination of factors that results in the dystocia, dysfunctional labor. So some complications. Oftentimes with dystocia, it's associated with increased maternal and fetal morbidity or mortality. It's the most common cited reason for performing a primary C-section. Clinical manifestations and diagnosis often occurs commonly once the woman is in active labor. So remember, active labor is going to be that 4 to 8 stage of labor. And it can also occur in the 2nd stage of labor, which again is complete dilation. She is a 10. So there's 2 types of labor dystocia: disorders of protraction, which is abnormally slow progression of the labor, or disorders of arrest. Now, to diagnose disorders of arrest, which means a total lack of progress, most doctors want that to occur for 2 hours. I keep putting my hand over there. Anyways, 2 hours. So no dilation, no descent for 2 hours. And conservative doctors will go all the way up to 4 hours. Okay, so there's different causes of labor dysfunction, and the uterine dysfunction, there's 2 different types. You have hypotonic, which is going to be that the contractions start, but they're not sufficient enough to carry the labor on. They don't promote cervical dilation. Or you have hypertonic, which is frequent contractions, but they're ineffective, they're not strong enough. And again, remember, if you're having contraction after contraction, you're not getting that good rest. You're not allowing the baby to get perfused, getting that blood supply, that oxygen supply to the baby. So that's called irritability. Precipitous labor is a labor that lasts less than 3 hours. And so most women are thinking, oh, that sounds great. But if your labor only lasts 3 hours, you are going to tear, you're going to rip. It's going to be really not a good situation for you or the baby. You'll have trauma, rapid descent. There's problems with that as well. Okay, so CPD, we've talked about this before, cephalopelvic dysportion. The diameters of the fetal head are too large to pass through the birth canal. Sometimes this is a macrosoma baby, a very large baby. It could be because of hydrocephalus, where the baby's brain is filled with fluid and that the head is just too large. They will not make it through the birth canal. The other reason is for pelvic types. They're not that gynecoid pelvic type, so the baby just will not fit through. Fetal malposition. Okay, remember we talked about positioning, and the position that is most favorable for birth is going to be that occipitate interior. So occipitate posterior is when that baby is facing up towards the ceiling. It's coming out sunny side up, face up. That's OP. Also malpresentation. So that baby's face is coming out of the cervix, full face. Of course, if you look, the circumference of my face is going to be a lot larger than the back of my head. So it's too big. It's not going to fit out. Breech presentation, transverse lies, compound presentations, all of those are not going to work. They will not make it out the cervix. Sometimes you can have a breech baby. There are complications with that, but typically what we want to see is that occipitate interior. Occipitate posterior, we're hoping that maybe we can change the position, change the baby's position by using different positioning on the mom, and sometimes that can take place. A lot of times with breech babies, it's about 3% of pregnancies will actually have a breech presentation. Okay, so I'm doing something different today and it's not working for me. Okay, posterior occipital, you can see where this bone is hitting the mother's bone. Okay, we want that to be back here. We want the back of the baby's head to be towards the front of the mom. Anterior occipital, that's the best way for a baby to come out. Okay, so nursing care, we're going to carefully assess fetal lie, presentation, and position. And the way we do that is through using Leopold's maneuvers. And you can see that in your book. It's just feeling to see where the baby is lying at. And sometimes if the baby is not lying in that position that we want, we'll be able to move them. And we'll talk about that in a little bit whenever we talk about external version. So we're going to assess the contraction pattern. We're going to be watching it every 30 minutes. Fetal response to the uterine contractions. We don't want to see any late decels, but we do want to see reactivity. A thorough pain assessment every hour, making sure that the mom isn't in pain, because again, we know that if she's in pain, if she's stressed, that can also slow labor. Again, one of those 4 P's. We're going to plot cervical changes and fetal descent on a labor graph, making sure that we are seeing progression, that she is dilating, her cervix is phasing. We want to see those things. We're going to determine if the woman might benefit from pain relief measures, and if so, we will offer her pain medication. Okay, so fetal malpresentation. The majority of pregnancies at term, the fetus presents head down. Breech presentation, there's about 3% that will end up being breech. And you can labor a woman who is in breech position. However, think about the buttocks of a baby. It's not going to be as hard, as firm as their head, and therefore it's sometimes harder for the buttocks to make dilation. It's just not as firm as the head. Transverse lie, of course, that's like the football lie. The baby, you'll see the mom's stomach and it'll look from side to side rather than up and down. And then factors that predispose to fetal malpresentation: if you have more than one baby, if you have placenta previa, hydranamose, and then contracted pelvis or uterine anomalies. Any of those things could make the fetal present differently. Clinical manifestations and diagnosis. There are 3 types of breech presentation. We'll go through those real quick. Frank is when the hips are flexed, the knees are extended, and it's also known as pike position. Complete means hips and knees are flexed, and also known as the Taylor position. Footling or incomplete, one foot or both hips are extended with one foot presenting. And then, of course, Leopold's maneuvers will kind of allow you to feel where that baby is. It allows us also to know where to put the fetal monitor. For more information on that, you can look at page 207, the procedure box, and kind of understand how you would do that exactly. Okay, so treatment for breech. A lot of times the doctor might go ahead and try an external version. So external version is on page 412, and it is actually done by a physician. He is manipulating the fetus through the abdomen wall to try and get that baby to turn, and that is very painful. Afterwards, for as far as nursing care goes, you might be giving the patient some tocolytics, which tocolytics allows the uterus to relax. If they're ordered, you would give them tocolytics, you would ask them to empty their bladder, and then the procedure is very uncomfortable, and we don't ever want to lie to the mom about this. It is painful, and then after the procedure, to all the Rh negative moms, you will administer Rogam, so that kind of tells you how painful it is. They can also use Piper forceps, and that's a process of manipulating the position of the fetus. With transverse slide, again, they'll try the external version. If they cannot get the baby to turn, they'll go ahead and do a cesarean delivery. Nursing care, like I said, we're going to position the patient. We're going to give ROGAM if ordered if the mom is RH negative. And then we'll have neonatal resuscitation supplies just in case any emergency were to take place. Okay, so, and of course with both of those, what are you going to do? You're going to check fetal heart tones before and after. Always check on that baby. Okay. Premature rupture of membranes. This occurs if it is before 37 weeks. So spontaneous rupture of the amniotic sac before the onset of labor. Preterm premature rupture of membranes is the rupture of the amniotic sac before the onset of labor in a woman who is less than 37 weeks gestation. So premature rupture of membranes, we're thinking 37 weeks and no labor. Preterm is before 37 weeks. Okay, so maternal and neonatal infection. Anytime that membrane, that sac, has been ruptured, that now there is no barrier for the mother in the vagina, in the cervix. There is nothing protecting them from infection now. And so as soon as the rupture of membranes happens, it automatically is starting to put them at risk for infection. The longer that they go with the rupture of membranes, the higher the risk is of infection. So some of the risk factors for preterm premature rupture of membranes: African American ethnicity, cigarette smoking, previous premature delivery, vaginal bleeding, low socioeconomical conditions. And again, just think about kind of where they're at and what they're taking place. Do they have good prenatal care? Anything like that. Sexually transmitted infections, again, high risk behaviors, and then conditions causing any kind of urine distension. So clinical manifestations, sometimes the diagnosis is very obvious and then sometimes it's not. There's several ways that we can diagnose it. The first is going to be nitrase paper, and what you would do is, it's a little thin strip of paper. It's usually yellow. You would put it up near the vagina and the cervix. If it turns dark blue, then you know that her membranes have ruptured. The other is for the Fern test. In the Fern test, you would take a cotton swab, swab some of the fluid, put it on a slide, and then if it ferns out under the microscope, that means that it is also amniotic fluid. Treatment, it depends on exactly what's going on. Chorioamnionitis is infection of the tissue. So if she has an infection, then we would go ahead and treat her with antibiotics. Moving on. Okay. Preterm premature rupture of membranes. What are we going to do for her? First, we're going to look to see if there's any signs of infection present. If there are no signs of infection, then we're going to give IV antibiotics followed by oral antibiotics. And the reason we're going to do this is all prophylactic. Then between 24 and 34 weeks, we're going to give her IM corticosteroids. And the corticosteroids are not so much for the mom, but as they're for the baby to mature those lungs. We're going to put them on strict bed rest and pelvic rest, meaning that no one's going to be going up and doing vaginal exams on her unless there is a reason. If she started to go into labor, she started to have contractions, then they would do vaginal exams, but they would still probably limit it and not do it as often. But until they have reason to believe that she might be dilating, she is on pelvic rest, meaning that nothing is going up into the vagina. And then fetal surveillance, always, always, always checking on that baby, making sure that the fetus is doing okay and tolerating all these procedures. Alright. Sorry, I'm trying something new today. Okay. Nursing care, we are going to assess the woman. We're going to maintain fluid balance, we're going to prevent injury, we're going to manage the woman's pain, and we're going to reduce anxiety. So you're going to also watch for temperature, make sure that she is not spiking in temperature. If she was, then we might have to start her on antibiotics. We would have to go figure out where the infection is. Expect continuous fetal heart monitoring, and report any abnormal signs to the RN. Okay, preterm labor is labor that occurs after 19 weeks and before the end of 37 weeks gestation. Anything prior to 20 weeks is going to be significantly poor prognosis for that baby. In fact, usually we say at 24 weeks, they have a good chance, that baby has a good chance of surviving outside the womb. But anything before then, it's really poor prognosis for that child. Okay, so the top 3 risk factors: a history of a previous preterm birth, current multiple gestation pregnancy, twins, triplets, or more, and then uterine or cervical abnormalities. Whenever we're trying to diagnose this, a definite diagnosis comes with any kind of cervical changes. If her cervix changes, that is preterm labor. Assessment of contraction frequency, we're going to be putting her on the monitor. We're going to see if she is still having contractions, asking her to measure them, and seeing if she is still in fact in labor. Another test that we'll do is the fetal fibronectin test. And this, we talked about whenever we were talking about labor readiness, but it's usually more diagnostic for preterm labor. And it's a protein that acts as a cellular adhesive, like glue, to help the placenta and the fetal membranes adhere to the uterus during pregnancy. So it's absent between weeks 22 and 37 weeks gestation. So that's another test that we will use. And then measurement of the cervical length. Again, that goes back to labor readiness, but with no change in cervical length in the presence of a negative fetal fibrogen test, that's saying that the woman has a very low chance of delivering prematurely. So if those things are increased, then we're worried about her delivering premature. And you can read more about that on page 415 in your book. Okay, so with preterm labor, we do not want her going into labor. We're going to want to stop that. And the way that we can stop that is through tocolytics. So we will administer tocolytics between weeks 24 and 33 weeks gestation to slow those contractions down. And tocolytics acts on that smooth muscle, so it stops contractions. And then we're also going to be administering corticosteroids for lung maturity. Of course, this is not for the mom's lung maturity, it is for the baby's lung maturity. And so those work hand in hand. We give her the tocolytics to hopefully slow down the contractions, make it where her uterus relaxes, and in the process, as long as she's not having contractions, the baby can rest, the baby can, we'll give the corticosteroids to the baby, and the baby's lungs will hopefully mature. We'll give them together, hoping that they work together. We can also give weekly injections of progesterone, and of course progesterone is that hormone that maintains pregnancy. So we're trying to be very proactive and keep the baby in the mother's womb for as long as we possibly can. Now remember, with this preterm labor, her membranes have not ruptured yet. We'll talk about that soon, but not just yet. Just keep that in mind. Okay, so the nursing process you can find on page 415. I want you to go ahead and go through that. Think about the assessment you're doing on this woman. Look at the selected nursing diagnosis and go through those. Planning goals. What are we hoping to accomplish with this woman? Do not forget emotional whenever you're looking through this. A woman who is facing a preterm labor is very worried about losing her baby, concerned about the health of the baby. So you have to address those issues as well. Preventing injury, managing pain, and reducing anxiety. All important goals. So important that I show them twice. Okay. clinical manifestations and diagnosis for post-term pregnancy and labor. So post-term is going to be anything after 42 weeks. So this woman is, she is past her due date, and so you can imagine her anticipation. She is ready to have that baby out. And a lot of times, this will happen because we have overestimated her due date. We didn't guess correctly. And so our big concern here is fetal lung maturity. We want to make sure that the lungs are fully cooked, I guess is one way of saying it. So we're going to do BPPs. We're going to make sure that the baby is doing okay. We also might do an amnio infusion. And why would we do an amnio infusion? Well, I'll tell you why we'll do an amnio infusion. After the baby has been in there for so long, you're going to start seeing that they're losing some of the fluid, some of the amniotic fluid. It's just not producing like it was. And so an amnio infusion is an infusion of sterile fluid into the uterine cavity during labor, just to give that baby more cushion, more fluid. We're going to be monitoring the woman. We're going to be telling her to watch and make sure she is always looking for fetal movement, that she's always monitoring that. We're going to be doing non-stress tests twice weekly, and then of course monitoring for fetal distress. Trying something new here, not working for me. Going back 1 second. Never mind, I'm not, because I can't figure it out. Okay, there we go. Going back 1 second, with a post-baby, there's a couple of things you have to think about with them. A lot of times, because that amniotic fluid is kind of drying up, you'll see that they have real tough, leathery skin. You'll also be concerned about meconium. Now, meconium is that first stool, and if they've been in the utero for too long, sometimes they'll go ahead and release that meconium, or if they're stressed, they might release it that way too. With that, you are afraid that the baby will take it in and have, of course, respiratory distress. Polyhydramnios is the low amniotic fluid. There's some concerns with that as well. With not enough fluid floating around, you're worried about that cord. You're worried about the cord compression again. And so you have to think about that as well. That is why we would do an amnio infusion, to give a little bit more fluid into the mother, the womb, to kind of cushion that baby. All right. Now we're moving on. Emergencies with labor and birth. Okay, so amniotic fluid embolism. Okay, this is very rare. It's an embolism from the amniotic fluid, and it can suddenly happen after delivery. The woman will become very short of breath, acute respiratory distress. She will demonstrate signs of cyanosis, hypotension, and it says that often it resembles more like septic shock or anaphylaxis than it does pulmonary embolism. Unfortunately, there's really no curative therapy, and so it's just trying to catch it as soon as you can and hope that not too much neurological damage has taken place. But luckily it's very rare, but it is very serious at the same time. Shoulder dystocia. So with this, the head often delivers, but you'll see this turtle appearance where the head pops out, but then it goes right back in. And so that is just that the baby is too big, the shoulder has gotten stuck. Sometimes the doctor is able to turn them, and then other times they'll have to do an emergency C-section. And the amazing thing is that they can do an emergency C-section within about 5 minutes, and they would have to in this case because the baby's already out. They have to go ahead and deliver that baby. Umbilical cord prolapse, we talked about this a little bit. A lot of times it doesn't happen a lot of times, But this is what you are monitoring for after premature rupture of membranes. You're making sure that that cord did not go through the cervix and that the head is compressing on that. Now, if this were to happen, this is an emergency. If you were the one who was with the woman, you would see that all of a sudden the fetus is gone into distress. You're seeing D cells, and you would look underneath the woman, pull up her gown, and you would see that umbilical cord is prolapsed through the cervix. And the way that you would handle this is to actually call for help, first of all, but throw the woman back as far as you can, put her knees up as high as you can to get pressure off of that umbilical cord. And then you might even have to kind of push the baby's head up off of that cord so that it's not compressing. And you would be doing an emergency C-section. Again, 20 minutes max, you're in there and the baby's out. Uterine rupture, we have talked a little bit about. Often this happens because of the suture lines or the incision line on the uterus. So again, emergency C-section. If that baby is not encapsulated and it's free floating in there, that's going to cause sepsis to the woman. The baby will not be able to make it more than 5 minutes, and so it has to be an emergency C-section as well. Okay, that's it.